Hi, my name is Sarah Monnier, and my presentation is over volar plate avulsion and fracture. Anatomy of the volar plate. It is multi-layers of fibrocartilaginous tissue in the interphalangeal joints. It originates from the proximal phalanx and inserts into middle phalanx. Ulnar and radiocollateral ligaments provide stability to the proximal interphalangeal joints. And the picture to the right shows all the different parts. Pathology of volar plate injuries is the stretching or tearing of the volar plate, which allows fingers to hyperextend, and is caused by direct trauma or diseases such as arthritis. Mechanism of injury is hyperextension of the fingers, a dorsal dislocation of the fingers, and fouching, which is falling on an outstretched hand. The Eaton classification is a type of classification that can be used when diagnosing volar plate injuries. The first is Eaton type 1, which is the hyperextension with avulsion of the volar plate and a longitudinal tear of the collateral ligament. Eaton type 2 is a dorsal dislocation of the proximal interphalangeal joint with avulsion of volar plate with a complete tear of the collateral ligament. Then there's Eaton type 3, which has two parts. The first part is 3A, which is a fracture dislocation with an avulsed small fragment less than 40% of the articular surface. 3B is exactly like 3A, except there's a greater than 40% articular surface. Predisposing factors are sports and past dislocations. Signs and symptoms of a volar plate avulsion and fracture is swelling, loss of joint motion, immediate pain, a possible dislocation, and pain on the palmar side of the joint. And the picture to the right shows a volar plate tear. Special test is a volar plate stress test. Differential diagnoses are an avulsion, which is a clean tear of the attachment points off bone. And then there's an avulsion fracture, which is a piece of bone pulls off along with the tear of the attachment points. Management and treatment of volar plate injuries is place the finger in a flexed finger splint, buddy taping, finger motion exercises, and surgery if there is a fracture. Referral and mobilization. The patient should be referred for x-rays to diagnose an avulsion or fracture. And then if the patient has an Eaton type 3B, they will require surgery. Prevention. There's no way to prevent this injury. No mulligan technique because it is an avulsion or fracture. My PCOT. There was 105 single distal radius fractures. They were fixed by repairing with volar locking plates compared to repairing with a bone augmentation. The outcome was that a volar locking plates are a reliable treatment method, and this was over a time period from January 2014 to December 2016. The next condition that I'm going to talk about is trigger finger, which goes along with volar plate injuries. Trigger finger is a condition where the fingers are stuck in a bent position. It is also known as senosing tendinosynovitis, which is the narrowing of sheath that surrounds tendon due to inflammation. And the picture shows you how the finger gets stuck in a bent position. Symptoms is stiffness of the finger, clicking or popping sensation in the finger. The patient is unable to straighten the finger, and there's tenderness in the palm. Predisposing factors of trigger finger is repeated gripping, health problems, past carpal tunnel syndrome surgery, and the gender of the individual. Treatment of trigger finger is taking NSAIDs to relieve the pain, rest, wear a splint at night, perform stretching exercises, and steroid injections. And then the PCOT that I found for trigger finger is there was 60 patients with trigger finger. 30 patients were treated with ultrasound guided needle release of the A1 pulley, which was group A, compared to 30 patients treated with single ultrasound guided corticosteroid injection, which is group B. The outcome was that group A had better outcomes of finger tendon function and joint function. And the time period this was performed in was from June 2017 to May 2019. And then here are my references.